Welcome everyone to the pre-session of our workshop on addressing the needs of an aging population through health professions education. This is such a critical time for us to be having this conversation. And I'm Donna Ferguson, and I am a mental health and wellness professional for the Department of the Army Criminal Investigations Command, and I'll serve as a co-chair this afternoon. I'm the co-chair of the workshop planning committee. My co-chair, Andrea Pfeiffer, she was unable to join us today, but we are thrilled that we have this opportunity for an accomplished group exploring critical issues of learning, reluctance to work with older populations. Our older population is so critical to us. And this is a time we've really got to pay attention so that we can protect the integrity for the future. So using implementation science to build evidence-based and information for future decisions on how we work well within the health science profession is so critical. So with that in mind, it is my honor and a great pleasure to introduce to you our opening speaker, Dr. Agnes Benaweho. Dr. Agnes is a Rwandan pediatrician who returned to Rwanda in 1996. 2 years after the 1994 genocide that occurred. Since then, she's provided clinical care in the public sector and served the Rwandan health sector in high levels of government, first as the executive secretary of Rwanda National AIDS Control Commission, then as a permanent secretary of the Ministry of Health, and lastly, as the Minister of Health for the last 5 years. This is such an opportunity for us to have her with us today. So Professor Agnes currently is residing also in Rwanda, and is also the Vice Chancellor and co-founder of the University of Global Health Equity, which is an initiative of Partners in Health, which focused on changing how healthcare is delivered around the world by training global health professionals, which we are a huge part of that. So I would like you to join me in please welcoming Professor Agnes Benaweho.
Thank you, Donna, for this kind introduction. Everything is right, except that I'm just retired at 68. So I'm no longer the VC since 1 week. But everything, the rest is correct. And I'm very, very pleased to be with you all, this high-level gathering you put together to discuss this very important topic in the health sector. So let's start. I think you have my first slide there. What I want to say is I want to take a few minutes to speak about the importance of incorporating implementation science into health professional education in general, giving the example of what needs to be done to fulfill the needs of aging population in particular. Next slide. We are all familiar with the research that goes into the discovery of different medical products. For instance, we have seen how quickly COVID-19 vaccines were developed in 1 year to respond to a crisis. When that successful discovery exists, funds are channeled into their production and the private sector take over to manufacture the new product. However, having this vaccine product don't mean that there will be health outcome, improvement in health outcome if those products doesn't reach the population. For example, in Africa, as of today, we have only 25% of the population that is vaccinated. In the US, we have 65%. And in both continents, it's always the well-off, the most educated, that are the best vaccinated. Additionally, contrary to the Western countries' commitment at the beginning of COVID, that if a vaccine is discovered, all the people at risk worldwide who are at risk, who have vulnerability, that means the elderly, the health professional, the people with underlying health condition, will be vaccinated in priority. It was not that at all. And less at risk population in the developed world were vaccinated far before people at risk in the developing world. So this approach of implementation science is helpful because it developed the know-how to avoid the distribute health product in a way that doesn't serve public health, but also avoid expiration of vaccine in all countries. We have how many thousands and thousands of vaccines were expired in Canada, in the US, in Europe, where those were denied in the developing world. It's to give also the know-how to reach population by fighting the hesitation against vaccination. Next slide. Now that we know what exists, the existing gap, I would like to give a formal definition of implementation research. According NIH, the US NIH, implementation research is defined as the scientific study of the use of strategies to adopt and integrate evidence-based health intervention into clinical and community setting to improve individual outcomes and benefit population health. So this is the definition. Next slide. There are various frameworks. Yes, sorry, I see it. Yeah, I lost you for a minute. There are various frameworks that are used within the field of implementation science. Here, we will discuss an hybrid framework that is used to understand the implementation of intervention through a lens of 5 steps. First, exploration. The exploration phase helps us to explore the contextual factors and the problem at hand. The second step is the preparation phase. We select evidence-based intervention based on data and local context. We collaborate with different stakeholders to ensure a holistic approach. No sector can solve the problem alone. Next, during the implementation phase, we select an implementation and implement strategies to ensure coverage of evidence-based intervention. The first step is the adaptation phase. We determine how, when, and why to adapt the evidence-based intervention and the implementation strategies at those 2 levels to ensure monitoring and evaluation system to understand what changes need to be done and where to get the expected results. Lastly, in the sustainment phase, we figure out how to ensure long-term implementation and sustainable outcome through integrating what we do in national policies, national strategies, action plan, and the budget. Next slide. Adopting an implementation science approach allows us to identify the facilitating and challenging contextual factors, as well as the strategies that could be used to either leverage or address these factors respectively. We can take the example of the emerging health needs of an increasingly aging population. As you can see from the graph on the right of this slide, the percentage of death and disease adjusted life years attributed to communicable diseases, maternal and neonatal and nutritional problems are decreasing, while the percentage attributed to non-communicable disease is increasing in low and mid-income countries, but also across the world. Understanding this context, we can design strategies to address the challenge. Strategies could include targeted health awareness, prevention program, as well as long-term treatment and end-of-life care. Next slide. Similarly, understanding facilitating contextual factors help us identify the strategies we can implement. In this case, if we know that a country has a strong community health worker program, we can implement strategies that include drug distribution at the community level or monitoring at community level by community health workers trained in follow-up of patients suffering from chronic disease. This is currently what we are doing in Rwanda for some programs, and it works well because it's from proximity, it's almost home care. Next slide. Once we implement the different evidence-based intervention using the strategies, we need to evaluate our success across various dimensions. In the implementation science field, we call these implementation outcomes. But you will notice that these are not limited to the health field. It can be applied to other fields. You can evaluate the cost effectiveness or sustainability of any program, whether a public health program or a new business program. But keep in mind that it is important to evaluate our implementation against all targeted outcomes. Otherwise, we will not be telling the full story of the impact of the program. Remember that a cost-effective program is not necessarily equitable. In fact, remember also that the term cost-effective has also been used to refuse life-saving medication and intervention to the low-income countries. Remember, at the beginning of the Ayurveda program across the world in the 90s, it was estimated too costly, too difficult to manage for treating people suffering from HIV in low-income countries. Next slide. We need to build implementation research capacity at all levels of the health system. A country with a health workforce capable of doing research and implementing non-evidence-based intervention out of those, the result of those research will have a stronger health system and will be ready to respond to new challenges better, such as the challenges of health needs of an aging population. Training healthcare workers, health system managers, policymakers, in-country researchers, and other relevant stakeholders in implementation research, either in designing and conducting the research or in the utilization of data generated by the research, are critical to build a flexible health system. And understand that health system is not health only. It's all the social determinant of health have to be concerned. Next slide. There is also a strong economic argument to capacity building in implementation research. Capacity building in research, and especially in implementation research, help us to use all known evidence-based intervention and implementation strategies that has been collected in the sector. This is key to strengthen health system and ultimately contribute to economic development, because health system that is strong have a population that are more healthy, And this process is cyclical, with poverty reduction because the population more healthy is more productive and the country and help more their country to fight against poverty. So it's an important factor to consider because it results also in improvement of health outcome, better economic status, better health outcome, etc. So it's a virtuous cycle. I thank you for your attention.
Wonderful. I will say to you, Dr. Ayas, thank you so much for getting us off to such a great start. This is so critical for us to talk about the role of implementation science within our health profession and education, specifically when we think about building the health workforce to take care of our older adults. I appreciate how you talked about evidence-based decision-making framework and really addressing the challenges of the contextual factors. And so we'll now turn it over to our next speaker, Kathy Maxwell. Dr. Maxwell is a professor at Vanderbilt University School of Nursing, where she researches outcome trajectories of our older adults related to the functional decline and frailty. So Kathy, the floor is yours.
Okay. Thank you, Dr. Ferguson. So hello, everyone. So I really appreciate the opportunity to begin this conversation about learner attitudes and working with older adults. My own work over the past few years has focused on educational and communication strategies. And so this topic is one that I'm very passionate about. Next slide. So let me start by providing some statistics and background that was published in Nature Aging in 2021. Globally, the older adult population will double by the year 2050. And in the US, it will increase from 16 to 22, 23%. In anticipation of this rise, the Institute of Medicine published the 2008 document, Retooling for an Aging America. But sadly, the effort did not produce results. In fact, the US saw a decline in geriatricians and nurse practitioners who work specifically with older adults, and that remained low as well. Despite this IOM report and other major national initiatives, barriers exist that have not been addressed. One major barrier is that of ageism among healthcare professionals, and unfortunately, ageism among older adults themselves. Next slide. In April 2021, Dr. John Rowe from Columbia University, who also served as the chairman and CEO of Aetna, he wrote a piece titled, "The US Elder Care Workforce is Falling Behind." And in the article, and using strong language, he addressed the rapidly growing deficiency in the workforce, noting that the greatest deficiency is in public health. He advocated for population-focused and evidence-based policies and programs to support well-being. He also addressed the need to implement recommendations regarding community-dwelling older adults with serious illness, noting the need to incorporate family caregivers, leveraging technology, advancing cultural competency, and developing refined payment models. Next slide. Unfortunately, ageism is a barrier to expanding our workforce for older adults. Published in 2020 in the International Journal for Older People Nursing, a study of 100 older patients and 87 healthcare professionals reported that not only does ageism exist, but that it's well established, socially accepted, and prevalent throughout the Western world. The World Health Organization views it as an active threat and barrier to an active aging framework and healthy aging programs. The study advocated for educational interventions to address ageism, education and training to improve knowledge about aging, and research to explore why ageism exists among older adults themselves. Next slide. And in May 2019, the Journal of the American Geriatric Society published a supplement on the healthcare workforce. The supplement addressed consensus-based recommendations, noting the need to leverage interprofessional teams, connect services, advance cultural competence, and address much-needed communication skills. The supplement emphasized the importance of the home care workforce, family caregivers, and high-quality palliative care. Next slide. In 2020, BMC Medical Education published a systematic review of literature that examined factors related to preferences of healthcare students in relation to working with older people and people with dementia. The review was comprised of and synthesized from 66 papers, including 56 unique studies that assessed the risk for bias. 7 categories of factors influencing preferences were identified, including the characteristics of students, learning experiences, courses, careers, older patients, and key work characteristics. Key findings showed that during student training programs, preferences for working with older adults actually decreases. The socialization process was seen as a deterrent and was referred to as a hidden curriculum. The review identified a lack of educational interventions to address this hidden curriculum. Perceived characteristics about the work, patients, and careers were another key finding. Students found that working with older people to be boring or emotionally challenging. Barriers included focus on quality of life versus cure, the nature of illnesses, communication difficulties, and negative aspects of patients' disposition. Only 2 studies actually addressed working with people with dementia, noting that the importance of exposure to healthy adults to reduce stereotypical prejudices and promote working with older adults. Next slide. In 2019, the National Hartford Center for Gerontological Nursing Excellence published core competencies for gerontological nursing. And I've highlighted key words from the 7 domains that they identified for these core competencies. In addition to maintaining knowledge and skills, clinicians should serve as positive role models for quality care. Educators should implement teaching strategies to develop knowledge, skills, and positive attitudes and facilitate interprofessional learning. Note that 3 of the domains address healthy aging, demonstrating the need to shift from such a strong focus on disease management to a more proactive approach. And finally, clinicians should demonstrate scholarship and leadership to advance education, practice, and professional development. Next slide. And so that brings me to the elephant in the room, a problem that we're not talking about, and that's the need for a paradigm shift in how we teach students to think about older adults and the ideas that shape our attitudes. Traditionally, thinking about older adults is static, with fixed ideas of young versus old, stereotypes and ageism verbiage, or mental pictures of old, frail people. How do we change learner attitudes? We don't have another decade to figure it out. Next slide. Compounding our problem, in 1975, in his seminal study, Dan Lordy purported that teachers are unlikely to engage in collective change because of 3 psychic rewards or orientations that impede improvement. Presentism focuses on the short term. Conservatism focuses on small-scale achievements rather than broad change. And individualism is reinforced and rewarded by jobs with uncertain criteria for successful performance and reliance on their own indicators in isolation of a broader agenda. So that leads us to this. Implementation science. It's the scientific study of the methods and strategies that facilitate the uptake of evidence-based practice and research into regular use by practitioners and policymakers, by those who are on the front lines. Next slide. Perhaps a broader, holistic approach is needed. A reality that receives little attention in educational strategies is that aging begins way before outward manifestations begin to appear. At cellular and molecular levels, mechanisms of biological aging take place over decades. If you picture an iceberg, most individuals have a long period with clinically healthy status. Once age-related pathologies and geriatric syndromes appear, it's often too late to reverse the mechanisms of biological aging, as individuals no longer have compensatory mechanisms and physiologic reserve to respond to stressors. Next slide. So in keeping with a more holistic approach, perhaps we need to advance understanding that aging is a continuum that begins around age 30, with slow and incremental decline that is unnoticeable in our younger years and even during much of our middle years. Nevertheless, changes are occurring at the cellular level, and we must figure out how to communicate the concept of the aging adult to the public to increase awareness, advance understanding of the importance of a shift in how we think about aging. In this pre-workshop session, our presenters will discuss implementation strategies for studying learner attitudes about older adults. Moderated by Dr. Aliki Thomas, an expert in implementation science, our panel will utilize a published study on service learning with older adults in care communities. The panel will discuss ways in which educators can use implementation science to adapt this study and others to the educational context. Some of the models of care promoted by leading experts and organizations are noted in this slide. Implementing them is the challenge. So let's dive into our panel discussion. I'll turn the virtual podium back over to my colleague, Dr. Aliki Thomas, who will introduce and moderate our